And so I am Joshua Langberg, and I'm a professor in the Graduate School of Applied and Professional Psychology and the director of the Center for Youth Social Emotional Wellness, who's collaborating with the Chancellor of Rutgers, New Brunswick, Dr. Francine Conway, to organize this webinar series. And I'm also serve as the Chief Wellness Officer for Rutgers University, New Brunswick. We appreciate you taking the time to be here today, and it is my pleasure to introduce Dr. Linda-Oshin, who is a psychologist and assistant professor at Rutgers University in the Graduate School of Applied and Professional Psychology. Dr. Oshin leads research on suicide prevention, racial identity, and mental health equity for youth and marginalized communities. She earned her Ph.D. in clinical psychology from the University of Connecticut and completed internship and postdoc at Yale University and Rutgers. Dr. Oshin's work on suicide prevention is featured in top journals, and she has received support for her work through the National Institutes of Health and the New York Department of Health and Mental Hygiene. Importantly, she recently co-developed a certificate program in suicide prevention, practice, and policy here at Rutgers, and she serves on the steering committee for the Suicide Research Symposium, which is a free and online conference for suicide research that is co-hosted with the American Foundation for Suicide Prevention. And so I'm grateful to Dr. Oshin for being here and sharing her expertise with us today.
Thank you so much, Josh. It's really exciting to be here to talk about a topic that I have been researching and passionate about for a very long time. So I will get started. First of all, I identify as a cognitive behavioral therapist, and I love to set an agenda. That's just what we do. And so our agenda for today will be to review some key definitions about suicide, to talk about some warning signs that you commonly see. Then we'll talk about how to assess for suicide. We'll talk a little bit about safety planning, which is what we ideally would do after we assess. And then we will talk about some distress tolerance skills from dialectical behavior therapy. And then I just wanted to highlight that we will have some time at the end for Q&A. If you are, as you're listening, if you have any questions, please do drop it in the chat. And I believe there's a question box or, oh, just a chat. Okay. So just drop it there and I will address them at the end. So with that, I just wanted to start with a moment of mindfulness. And for people who may not be aware of mindfulness, I think a lot of us are aware of mindfulness now. It's become kind of a buzzword. But mindfulness is really just being aware of what's going on inside you and around you in the present moment without judgment, just noticing what you're thinking, what you're feeling, and what's happening around you. And so I wanted to take a moment to notice maybe what was happening right before you logged in to the seminar, and if you're carrying any of that with you. And I like to practice mindfulness with my eyes open because we live with our eyes open. But just take a deep breath and just stop and notice what's going on. I'm going to do it too. So I encourage you to just kind of keep taking some mindful breaths. Just try to notice how you're feeling. How often do we get to do that, right? We usually rush around for day to day, and it's kind of a gift to just kind of stop and notice. Um, I always like to do this, especially when talking about suicide. I've been researching and working clinically in suicide for a long time, but it's important to stop and remember that we are talking about a really heavy topic. And given that suicide is the second leading cause of death among youth and college-age adults, and is also very common in other age groups as well, um, it's very likely that many in this webinar have been affected by suicide, or have maybe struggled with suicidal thoughts or suicidal behaviors themselves. And so I just want you to be mindful of that, and encourage you that, first of all, you being in this webinar is being a part of the solution. And at the same time that, if you feel as though it's difficult for you to be in this seminar, then I just want you to be aware of that and, proceed with the seminar mindfully. So with that, I'm just going to take one more deep breath. I can't help myself. And then we'll get started. So let's start with some key definitions with suicide. First of all, suicide itself is the act of killing oneself with the intention of ending one's life. And so that intention is really what we care about when we're thinking about suicide. And this is, we are talking about a death, and that's kind of stigmatized, talking about death, especially in our society. And suicide itself is highly, highly stigmatized. And so I just want to highlight that I try to be really intentional with my language when we're talking about suicide in an effort to dispel some of that stigma. One of the ways that we can do that with our language is to, when, if somebody does die by suicide, to talk about them dying by suicide rather than saying, commit suicide or completed suicide. And that's really because, suicide is an act that is often done in the midst of a great deal of pain. And for a long time, that was kind of ignored and it was seen as, an inconvenience or, something that was done selfishly. And in fact, the phrase commit suicide actually comes from a time when suicide was criminalized, which it actually still is in many countries, and was treated like murder, where you commit murder, you commit suicide. So I really encourage us to try to, think about suicide in the realm of emotional pain and try to treat it with some compassion. Another term I want to introduce you to is suicidal thoughts, or if you're fancy, you can call it suicidal ideation. And these are thoughts about killing oneself. Um, Suicidal ideation or suicidal thoughts, they're actually very common. And it's possible that a lot of you in this seminar have had thoughts about suicide. It might range from thoughts about, like, I wonder what it would be like if I wasn't around. Maybe an intrusive thought about, like, we all had that, moment when we're standing on top of a really large building or a cliff and we think about jumping off, all the way to, having thoughts about, actively trying to kill oneself, having a method, having a plan, things like that. So I just want to highlight that there's a lot of variation and that suicidal thoughts are actually pretty common. Next, we have a suicide attempt, which is any action that's done with the intention of ending one's life. Actually, if you were to talk to a bunch of different, like, suicide researchers and clinicians, we would not agree on a definition for suicide attempt. So if you're like, I don't know, that's okay. That's a definition I'm working with. I like this definition because I work with a lot of teenagers, a lot of youth, and sometimes they might engage in a behavior, and you're not quite sure if that was a suicide attempt because maybe they don't have access to lethal means, or maybe they're just not aware of what would be lethal. And yet that intention, again, is what we really care about. So even if it was a behavior that, you wouldn't really be that concerned about, but if somebody had that intention to end one's life, I would consider that a suicide attempt and I would take that very seriously. And finally, I wanted to highlight something that is sometimes confused with a suicide attempt, and actually is kind of one of the risk factors for suicide, but is a distinct thing, which is non-suicide self-injury, or you might have heard it called self-harm. So these are actions that are done with the intention of hurting oneself, but without the intention of dying. So you might see this in terms of, cutting, burning, scratching oneself, but there's no intention to die. It's just an intention to hurt oneself. It's still very concerning, and yet it's not what we'd call suicide attempt. So we just think about it a little bit differently. So those are the kind of definitions and the terms that we'll be working with today. Next, let's talk about some warning signs for suicide. I'm going to start with emotional warning signs, and then we'll talk about behavioral and mood warning signs later. Emotional warning signs are a little bit less obvious. You really don't know unless you're talking to somebody and they're sharing openly about what they're feeling. And yet it's important for us to know what might be going on emotionally for somebody if they're thinking about suicide. So if somebody is saying that they're in just a great deal of emotional pain, if they're experiencing hopelessness about the future, about themselves, if they're dealing with a lot of guilt or shame, or if they feel some way like a burden. These are some kind of emotional experiences that might put somebody at risk for attempting suicide or thinking about suicide. I always like to think about behavior and mood warning signs because a lot of people might be having thoughts about suicide and they may not actually tell somebody. And so these are some kind of red flags that you might see amongst a loved one or a client that might just kind of put that thought in your head. Is like, is this person potentially thinking about suicide? First of all, we do know that if somebody has had a previous suicide attempt, they're much more likely to attempt in the future, especially if it was a recent suicide attempt, especially if somebody is recently discharged from the hospital after a suicide attempt. We know that those months following a discharge, there's actually really high risk for another attempt. If there was a recent suicide death in their social network, so if a friend or a loved one recently died by suicide, everybody in that network, their suicide risk actually goes up. And I also, now that we're in a digital age, if there was a high profile suicide death, especially one that was reported inappropriately, that also raises suicide rates, and suicide risk. We already talked about non-suicidal self-injury. So again, that's if somebody is harming themselves without the intention of dying. Again, that's not a suicide attempt, and it is still a risk factor for suicide. It's an indicator that somebody is usually experiencing a lot of emotional distress, and something we need to be aware of. If somebody is engaging in drug or alcohol use, and especially if that drug or alcohol use has been increasing, that's usually a risk for suicide as well. And the way that we think about this is that they're just less inhibited, and so might be more likely to act on a thought, whereas, if they weren't using substances, then they wouldn't. If somebody is experiencing chronic illness, that's a risk factor for suicide. And if they are in a great deal of physical pain, that can be a risk factor for suicide, especially if that's a change, if they have a recent diagnosis or a recent escalation in pain, or a recent escalation in their chronic illness. If there are any changes in sleeping or eating in either direction, if there's more sleeping or more eating, or less sleeping or less eating, this can also be a warning sign that somebody is at risk for suicide. It can actually be kind of a vulnerability, especially sleep can be a vulnerability that might kind of put somebody on the path to a suicide behavior. And finally, if somebody is engaging in any planning, that's usually a warning sign that they're thinking about suicide. Unfortunately, in this day and age, there's a lot of websites that have information about, how to effectively die by suicide. And so people might be going to those websites or, doing a suicide note or talking to their friends or family about it. That is a warning sign that somebody is thinking about suicide. One thing that's not a warning sign for suicide is if another person asks that person about suicide. Sometimes people are worried about asking about suicide because they don't want to put an idea in somebody's head that wasn't already there. There's actually been a vast amount of research to show that's not the case. And in fact, we want people to be asking about suicide. So I encourage you, of course, it's hard to ask that question. And I don't want the concern that it's going to put an idea in somebody's head to stop somebody from asking that question. So you might be wondering, how do I ask? How do I ask about suicide? So that's what we're going to talk about next. First, I just want to highlight, especially for parents or loved ones, I just want you to ask yourself, if you are thinking about asking that question, why are you asking that question? What have you noticed that is leading you to want to ask that question? There's probably something, a red flag, something that's really concerning, and it's important to keep that in the forefront of your mind. And also to remember that you are asking this question or these questions because you're concerned about this person. This is a person that you care about, and you want to keep that person safe. So I want you to keep that in the forefront of your mind because it's hard to ask about suicide. You need a lot of courage. And so you really want to just kind of keep that in the forefront of your mind. And if you are a clinician, I also want you to ask yourself, why are you thinking about asking this question? What warning signs did you see? And also, what are your obligations if the person says yes? A lot of times, and I have been in this situation myself, despite all my training, that I have asked the question and then been like, oh no, I actually don't know what to do now if somebody says yes. I don't know what the policy is. I don't know what I'm supposed to do, what my obligations are, especially clinicians are frequently mandated reporters. And we may not have kind of laid groundwork beforehand about saying, if you say yes, then I have to do this. And so it's really important to kind of stop and ask yourself, why am I asking or what are my obligations if I do get a yes to this question? Second, I want you to kind of check your language and be really thoughtful about how you are talking about suicide. As I said before, there's a lot of stigma about talking about suicide. A lot of people don't feel comfortable talking about it. They might use a lot of euphemisms. One that I've been hearing a lot is unalive. I wanted to unalive myself. And so, you want to see, how are you talking about it? Are you using, helpful language that's clear? And what language are they using about it? I like to use the language that the person who I'm asking is using. And I also like to push for more detail. So if somebody is using a euphemism as I'm asking, say, yeah, I've been thinking about, unaliving myself, I might say, what specifically to you does unaliving mean? Because we do want to be detailed when we're asking about suicide. And finally, I just want you to, while we're checking our language, to also make sure that you are checking yourself and making sure that you're listening. When we talk about suicide, a lot of anxiety comes up, and people can sometimes stop listening when they're anxious. And yet, if somebody is saying that they are thinking about suicide, this is somebody who's in a lot of pain. And sometimes the best intervention is to just listen to them and to hear their story. So I want you to kind of take a step back, noticing anxiety that you might have about the interaction, and make sure that you're listening and being thoughtful about your language. For the clinicians in the Zoom room, I highly, highly encourage you to use a tool, use some type of measure as you are assessing for suicide. I really like the Columbia Suicide Severity Rating Scale, or the CSSRS. I'm going to drop a link for that in the chat in a minute. So here's the link for the CSSRS. It's an interview-based tool that you can use that really kind of leads you through. It's kind of got like a flow chart of like, if they say yes, then you do this. So that's really, really helpful. There's also the ASQ, or the Ask Suicide Screening Questions, and I'm going to drop the link for that as well in the chat. So that one is a self-report measure that you can use. Not only is it just makes it easier for you if you have something to kind of guide you through as a clinician what you're supposed to do, it's also really helpful for liability reasons, right? So you want to kind of document, obviously, if you are assessing for suicide. And it's really useful to say, not only did I, ask these questions, but I used this empirically supported gold standard tool to ask for suicide. So I highly encourage you to use those. They are freely available, and they're really good. But what they all kind of have in common is that they assess these three components of suicide. And so, even if you don't have access to a tool, or if you're a loved one and you're like, I'm not going to pull out a tool, I just want to know, what should I ask? Of course, you want to say, have you thought about suicide? And then you want to assess a little bit more. How risky is this person? How concerned should I be? So the three kind of domains that we want to think about are intent, method and access, and plan. So intent is, what we already talked about this. What is your intent behind this, behind the thoughts that you're having? And if you are thinking about suicide, do you intend to act on it? Or is it just something that you've been thinking about? So that's intent. Method and access is, have you thought about how you would die by suicide, how you would attempt suicide? And do you have access to the method that you have been thinking about? Oops. Especially if we're thinking about somebody who might have access to a firearm, do they have a firearm in the home? If they've been thinking about, jumping off of a tall building, have they thought about which tall building, things like that. So that's method and access. And then plan. Have they actually started to make a plan about how they're going to make a suicide attempt and die by suicide? Have they thought about where and when? Have they made a suicide note? Have they started, giving possessions away? We want to know, how much have they thought about this and, how likely is it to happen? So those are the three components that you want to be assessing. And again, if you're a clinician, I highly recommend that you have a tool at your disposal to use as you're assessing for suicide. So you've assessed for suicide. Somebody has said yes in some capacity. Now what? Now what do I do? Of course, if you're a clinician, you should be aware of the policies in your setting and your obligations. And at the end of the day, what we're really interested in is safety. We want to get this person safe in some capacity. And the question is, what does safety look like for this person and their level of risk? What would feel safe for them? What were they kind of looking for? And, given their level of risk, what do they need? So we usually think about this in terms of kind of high risk, moderate risk, and low risk. High risk, which is somebody who does have an intent to engage in their behavior, they have a method, they have a plan, they have access to their method. That's what we would call somebody who's at imminent risk for suicide, that we're really, really concerned about them and we need to get them to safety ASAP. So this is somebody who, cannot commit to not engaging in suicidal behavior. They have intent, they have method, they have plan. At that point, we need to start thinking about emergency psychiatric services. So, the goal would be to get them to an emergency room or to call 988. And get them evaluated and potentially have them in an inpatient unit. That being said, even if somebody is at high risk, it's still helpful to have a conversation about what feels safe for you. Especially a lot of people may not feel comfortable with a call to 988 or are understandably distrustful of emergency services, especially the police, or distrustful of formal mental health services. They don't want to talk to a therapist. And so even if you do have these obligations, it's still helpful to have a discussion about, what does feel safe for you, and how can we go about you getting to safety in a way that feels nice to you, that feels it's going to be safe, that you're going to be understood and going to be heard. So it's nice to have that conversation. It's also really, really nice. This is a scary situation, right? And if anybody's ever been in an emergency room, I unfortunately have. I have two kids. I've had to be in the emergency room a lot. It can be a scary and chaotic place. And so if you are a loved one, it can be really nice to go with that person to the emergency room or to call 988 with them, just so they can have another person there to help them feel cared for and safe. Um, and I recommend, if you're working with somebody who is a Rutgers student, the campus counseling services are incredible. And they do have, I actually checked right before I got into this call, every campus, New Brunswick, Newark, Camden, they have very clear suicide crisis services on their websites. That are kind of targeted towards the specific community, to what's going on in New Brunswick, what they have access to in Newark, and what they have access to in Camden. So I encourage you to go to those websites and see what they have access to, just so that you can have those tools available to you. And especially if you're working with a Rutgers student, that they can, seek help within their own community. So, as a clinician, you have to kind of balance like what feels safe, what feels good for this person, what are your obligations. Sometimes it's a really, really tough call. And, we want to proceed with a lot of validation and make sure that we're kind of prepared before we go into a talk like that, so that we at least know what we have access to, what we have to work with as we're trying to navigate this with somebody. If they're not at high risk, now we have a little bit more wiggle room. And so we want to think about, what do they need at this moment to help them to not get into a high risk category. And a really helpful option that you can have that, might kind of avoid somebody having to go to the emergency room or having to go to the inpatient unit, is a safety plan. So let's talk about safety planning. A lot of you have probably heard about safety planning if you're a clinician. I'm going to drop this link in the chat for Safety plans. I really love this website because not only do they have the safety plan available, but it's also in many, many languages. So I encourage you to visit that website and download a copy of a safety plan just to have. But it is an intervention that you can give to somebody. And the goal of the safety plan is really to help them collaboratively make a plan for if they are struggling with suicidal thoughts and worrying about their safety. If they leave your conversation and things start to get worse, what should they do? And what I really like about the safety plan is that you can have it written down because when you're really upset and distressed, it's really hard to think and to remember things. You might have said just 2 minutes ago, yeah, sure, I'll do that. And then be like, what's that number? What did I say I would do? And so the safety plan has it all written down and split into categories so that people can know what to do. So it has a couple of components. I'm going to walk you through them. The first one is warning signs. I like to think about these as red flags. What is a sign to this person that things are kind of going downhill, that they're starting to think about suicide again, that things are getting worse and that they're at risk, or they're worried about their safety? So it might be things like, if so-and-so calls or texts again, if they feel shame, if a certain thought pops into their head, if they feel something in their body, maybe their stomach is hurting or they're not sleeping or something like that. What for them, because everybody is unique, what for them is a warning sign or a red flag that things are getting worse and they need to seek some help? Next is internal coping strategies. What can they do to help themselves? What do they tend to do when they're feeling really upset that feels good, that helps them to feel better? You can write down what are some things that they can do to make themselves feel better. Sometimes it can be nice to give some examples yourself of what helps you to feel better so they can maybe have some more options, some more things to choose from. Next is external coping strategies, or as I like to think about it, distraction. What can we do to kind of get people out of their head, out of this situation, and ideally with other people, because we know that when people are connected socially, they're much less likely to make a suicide attempt or something like that. So who can you call who is really fun? Is there a show that you can put on, something like that? So we really want to talk about people. So it's not necessarily a person who you would call to ask for help, but it could be somebody who you could call or text that will help you feel a little bit more connected and can kind of distract you. So it's like, do I have a friend who I talk about my favorite show with? Or can I go down the hall in my dorm and, I know someone's always has their door open and so I can chit chat with them. These are the kinds of things that you want to put under external coping strategies. The next one is people who can help in a crisis. So these are the people who the person should call if they are really struggling, and these are the people who can get them to safety. So maybe it's a parent, maybe it's a loved one, a friend. Who can they call? Who's a ride or die person who we know, like no matter, day or night, they're going to pick up the phone, they're going to answer the text, and they're going to help you. Who can we put under this list? The next one is professionals and services. Do they have a therapist already? Put their phone number on there. What are some hotlines or some warm lines that they can call that they feel comfortable with? There's, 988, of course. There's the text line. There might be some kind of specific ones to their area. The Trevor Project has a text line and a hotline for people who are LGBTQ plus. There are a lot of options for people, and so it can be really helpful to write them down so they can see, actually, I have a lot of options of people to call who are professionals who can make sure that I can get some help in the moment. And finally, we want to think about how can we make the environment safe. So especially if somebody has thought about a method, how can we make sure they don't have access to that method? It might just be, for the sake of time, this period, while you're really struggling, should we take this thing away? Should we take the pills away? Should we make sure you're not on the walk towards that really high cliff that you've been thinking about, throwing yourself off of, things like that? And one really important thing to ask about, whether or not they've thought about dying by suicide with a firearm, is do they have a firearm in the home? Do they have access to a firearm? Just because we know that if they have access to a firearm, they're very likely to die by suicide by that firearm. And it doesn't mean that we have to take it away necessarily. There's actually a lot of options of, getting a lock, putting it in, a safe place, a locker. A lot of gun shops actually have places where you can store your gun. So things like that. We want to kind of stop and think about, what can we do with that firearm? So the key for safety planning is that you really want to do this collaboratively. Especially those of us who are clinicians are probably highly aware of the suicide safety plan. And I have been guilty of this, handing the paper to them and then walking away to go deal with something else. Because we're busy, especially if you're in an emergency room or something like that. But we really want this to be a collaborative process. We want them to feel heard and to have an opportunity to brainstorm about what can they actually do to keep themselves safe. And if they can't keep themselves safe, where should they go? What should they do? What happens a lot with safety planning is, especially when you get to internal coping strategies, is people say, I don't have any, or I have some, but they're not working right now. So what we're going to do next is talk about what are some coping strategies that maybe we can introduce to people that will help them if they're in a really tough spot. So we're going to talk about distress tolerance, how they can kind of tolerate the moment. These are skills that come from a therapy called dialectical behavior therapy, which is a treatment that has a lot of evidence for suicide and self-harm behaviors. And the goal for distress tolerance is really to get through a moment without hurting themselves or to make the situation worse. So even though, I'm talking about this in the context of suicide, we could all use some distress tolerance skills. So I hope you're all listening up. We all feel distressed at some point. And so they're really helpful to just get through a moment without making the situation worse. Just get through the moment. So first, what is distress? Distress is, if we think about a scale from 1 to 10, 1 is super chill, the chillest you've ever felt. Everything is good. You can stop and think, what is the chillness? Maybe it's on a beach with a book and a beverage or something like that. That is 1. 10 is the most distressed you've ever been. If you've had a panic attack, that's a 10. The time that my 2-year-old locked me out of the house, that was a 10. So that is the kind of range that we're working with. Distress is at the upper end of that scale. We're thinking like a 7 to 10. This is, highly, highly distressed. And so it's important to define that because sometimes people will think about distress tolerance skills in a not so helpful way. Importantly, the goal for distress tolerance is not to get down to a 1. I would love to be at a 1. I'm not at a 1 right now. I am in a seminar with 127 people. I'm not at a 1. I would love to be at a 1. Distress tolerance is not going to get me to a 1. The goal of distress tolerance is maybe to not go from a 7 to a 9, maybe to go from a 9 down to a 6, or to not go up even more. So we're really trying to make it work and get through a moment. We're not trying to get down to 1. And so that's really key to explain to people and to know for yourself because sometimes people will use a tool and be like, it's not working. But it actually might be working. Maybe it stopped you from escalating even more or just brought you down to a level where you can tolerate this level of distress. So we're really thinking about like a 7 to 10. And if people really like that skill, you can say like, what number are you at right now? And then do a skill and then what number are you at again? So the first skill I'm going to introduce is called the tip skill. And the idea of this is to really kind of tip your body chemistry towards calming down. In DBT, we love an acronym. So if you don't love an acronym, I apologize to you. We love an acronym in DBT. And it really helps you to remember these things. So TIP is really using what's called your parasympathetic nervous system to kind of counteract like your fight or flight. So we know when we're really distressed, our bodies respond in a specific way. And you can think about when you're really stressed, you sweat, you start to breathe faster, your heart rate goes up, and maybe your body gets really tense in certain ways. Your body is getting ready to like run from a bear. And so that is what's going on when you're distressed. Tip skills are trying to counteract that and use the systems that your body have to calm yourself down and get yourself down from a 10 into a place where you can think a little bit more. And what I like about these skills is that They're not so much in your mind because when you're really distressed, when you're at a 10, you're not thinking very clearly. And so it's hard to do a very cognitive skill if you're really, really upset. So TIP stands for temperature, intense exercise, paced breathing, and progressive muscle relaxation. The first one, temperature, is using ice or coldness to calm yourself down. There's actually a response that your body has called the diver's response, which is your body's way of trying to preserve oxygen if you were to dive into a cold body of water. If you were to be thrown into a cold body of water, your body would try to conserve oxygen to keep you alive. And so we're going to use that response system to try to decrease our heart rate, decrease our breathing. So the ideal way you would use this is if you got a bowl of water, filled it with ice, and dunked your head into it. You want to ideally have it up to your temples. Yes, your hair is going to get wet. That's okay. It's going to get you through the moment. Ideally, you actually had the bowl of water in between your knees, so you could like dunk and have your head down to kind of simulate that diving response. Um, it is uncomfortable and it works. So that is something you can have at your disposal. If the supplies are not working with you and you don't have that, then you can use some type of coolness. So I've had, patients take a cold shower, or have ice packs and stick it on their face. It can be really, really effective and lowering your heart rate, lowering your breathing, calming yourself down. So that's temperature. Next is intense exercise. The goal of intense exercise is to kind of escalate your heart rate. You do something that's going to raise your heart rate. Maybe go for a run, maybe do, some jumping jacks or something to get your heart rate up. And then your body will just bring the heart rate right back down. And so that can be highly effective if people are really, really distressed. The next one is paced breathing. The goal of paced breathing is to breathe out longer than you breathe in. And people have their own counts. We hear a lot about like 4-7-8 breathing or box breathing or things like that. You can kind of test it and see what works for you. I'm not going to give you a certain count, but the goal is really to breathe out longer than you breathe in, and that will kind of slow your body down, slow your heart rate down. I like to breathe in for 4 and breathe out for 8 if you really need a count, but everybody has different lung capacities. So try it out and see what works for you. And then finally, we have progressive muscle relaxation. So we know our bodies get really tight if we get really stressed out. Again, it's trying to run from a bear. And so you can use progressive muscle relaxation to relax your muscles. And so what you do is you find whatever part of your body is tight. For me, it's usually my shoulders, and you tighten it as hard as you can. That's the key thing, as hard as you can without hurting yourself. And hold it for 10 seconds, and then you release. And actually, when I just did that, and my shoulders went down even further. So it actually relaxes your body more than it did beforehand. So you can have people do that to whatever part of their body is really tight, or just have them start from the top of their head and move their way down their body. Do the forehead, do the cheeks, do the shoulders, do your stomach, do your thighs, and have them kind of relax their entire body. So that's tip skills. The key things about tip skills is, first of all, a lot of these are working with heart rate. So if you do have a heart issue, some type of cardiovascular issue, I recommend you talk to a doctor before you do some of those things. And another key thing is you have to practice it before you're in the situation. So when we're leading skills in like a skills group, we actually will have a bowl of water or some ice packs, get people to do jumping jacks, things like that, to practice it before you're in that situation. Because if you're in the situation, you're going to be like, where's the ice? How do I do this? I don't know if this works. Oh, I don't like it. And so you want to practice it beforehand. And I encourage you, when you're practicing, if you do have like a heart rate monitor, like a lot of us have these smartwatches, to actually notice what your heart rate is before you do it, and then notice what it is afterwards. Always think that's really cool. So those are tip skills. I hope you find them helpful. I use them all the time. I used it before the seminar, did some paced breathing to calm myself down, and I hope you find them helpful. Next is to use what we call accept skills, or accept the moment. In DBT, is called Wise Mind Accepts. The goal in these skills is to kind of use some activities to get through the moment. and to kind of distract yourself. The key is to really distract yourself, accept that you are in a difficult moment, and then distract your way through it. So the first one is activities. You got to do something. Just do anything. Go out for a walk, call or text your friend, go do the dishes. Just get up and do something. This is for people who are CBT therapists, behavioral activation. You get up and do something, get out of your head. Anything, just get up and do something. Do something to contribute to another person. If they have a sibling who's younger, maybe go help them, maybe go volunteer somewhere to just remember and feel connected to other people that, even if I'm not feeling so great about myself, I can still be of service to other people and feel connected to other people. And it feels nice to you as well when you help people. They're usually happy. They usually express that to you, and that makes you feel better. So that can be a really helpful thing to do. Comparisons can be helpful. Some people don't find this helpful. I would say DBT skills always work, but they don't work for everybody. So it's helpful to, see what skills work for you. Comparisons is to think about in what way it could be worse. Is there a group of people who are maybe suffering, and you just kind of think about them and think, well, yes, I'm having a really hard time, and at least I have food on the table. At least I have a roof over my head. At least I have access to some services, things like that. If that is not helpful, another way you could use this skill is to compare your current version of yourself to a previous version of yourself. So you could say something like, yes, I'm having a really hard time right now. And I've been through some really hard times. In fact, maybe I've been through some worse times and I got through that and I can get through this. Or maybe I have access to more resources now. I'm in a better place now. So that can also be really, really helpful. Emotions, E is just try to create a different emotion. So sometimes we try to, if we're feeling bad, we try to do something that will validate our emotions. So if I'm sad, I'm going to listen to a sad song. Nothing wrong with that. But if you're really, really distressed, sometimes you could try to do something to create a different emotion to kind of distract yourself and get yourself out of your funk. So maybe listen to a happy song, watch a funny video, something to kind of create a different emotion. Just push it away for P. Find some way to push it out of your mind. For people who are good at visualizing things, you can build an imaginary wall between yourself and whatever problem or whatever emotion that you're experiencing. Put it on a box, put it on a shelf in your mind. Just find a way to kind of push it away from yourself and create some distance between yourself and the emotion. Find a way to replace the thoughts. So find something that will be very distracting in your brain. So maybe do a crossword or a Sudoku, or do something that will just take up a lot of space in your brain so that you're not thinking about this really distressing thing. And finally, try to intensify other sensations. Try to kind of get out of your head and get into another part of your body. So pick a sense, we've got 6 of them, and try to find your way through it. So those are 2 distress tolerance skills that can be really helpful. Tip skills and accept the moment. Again, I said before that DBT skills work. They don't always work for everybody. These may not work for you, but you try to test a few and see what works for you. And same for the person who maybe you're helping through a difficult situation is try a couple and see what works. And I always like to highlight that the more distressed you are, the more skills you need to use. So you don't want to just use one skill and be like, ah, it's not working. Maybe use a couple, especially if you're at a 10, you probably do need to use a couple skills or several skills to try to get through the moment. And again, just highlight that we're just trying to get through the moment. We're not trying to get down to a 1. This isn't going to solve your problems. It's just trying to get somebody through a difficult moment so that they don't hurt themselves or make the situation worse. You do want to practice these before you need them because you don't want to try a new thing when you're at a 10. That's not a good time to try a new thing. And again, the more distressed you are, the more skills you need to use. So don't just pick one. So that's it for my seminar. I just wanted to highlight, if you are enjoying learning about DBT skills and you want to learn more about how to live a skillful life, we have a group at Rutgers called DBTRU, DBT at Rutgers University, that created these beautiful animated skills videos, not just to stress tolerance, other types of skills to help you live a more skillful life. So I will drop the handle in the chat so you can go find them on YouTube. They're very cool. I did not create them. I just really enjoy them. I hope you go and visit that and that they are helpful to you. And thank you so much for having me. I'm going to take a look at the chat. I'm sure people have questions. Um,
I had
oh,
one question if we could start that came directly to me.
sure.
Can the ASQ be used with kids or teens?
Yes, yes. So they have been developed for kids or teens. I think if you go to that website, there's like a separate thing for kids or teens. I think mostly for teens. I will say that doing suicide assessment with kids, unfortunately, is a huge area of research. We need to do more research on that. We do know that suicide rates are escalating, especially among preteens, and we don't have great tools for that. So sometimes you have to kind of in the moment think about like, how can I translate this to like a 9-year-old? But yes, the ASQ can be used with teens and the CSSRS has been used with teens as well. A lot of people are asking for the slides and the recording. I'm not sure how we
We
can.
will, yes, thank you for asking. All of the presentations are being recorded, and as soon as we can compile them, we will send out a link to everyone who is registered, and we will also ask the presenters for their slides, yeah, and share them as they're made available.
Yeah, I'm happy to share my slides. Somebody asked if any of these skills can be incorporated into a classroom setting. There actually is an intervention for DBT for schools called DBT Steps. So you can do that in the school setting. Or you can just kind of pick and choose a couple if you're a teacher, and walk people through them. I think that's really helpful, especially in a school setting. Actually, a DBT skill that we haven't talked about today that I find extremely helpful in a classroom setting is what's called Dear Man, which is how to ask for things effectively. And so I usually, with my students at the beginning of the semester, we'll actually walk through the scale and be like, if you want an extension, you better send me a Dear Man and ask effectively for it. So yes, I do encourage you to incorporate them into a classroom setting.
I had a question come through. There are numerous apps. Are there any you think helpful of tweens and teens? What's your opinion of the apps in general?
Yes, there are a lot of apps. I'm not like super well versed on them, but there is something called the Hope Kit, which has a lot of evidence for. I would recommend if somebody is downloading an app, especially a kid, that obviously parents should probably take a look at it and to see if it is empirically supported in some way. There are a lot of apps that are working with mental health professionals, with researchers to make sure that they are using evidence-based strategies. So make sure that they are that they're supported in some way. Mhm. Anybody else? I'd love to answer any questions that people have. Here's one. Any tips about performing risk assessment and any strategies in working with special needs kids? Yes. A student who is black and white thinking and often goes to extremities when upset. This is a great question. And again, I will say this is a limitation in our field. With people who have special needs or are neurodivergent in some way, especially in the autism spectrum, we really need to work on that. And I will say that, for people who are special needs, it really depends on what the special need is. But I have kind of defaulted to more of the kind of behavioral strategies than cognitive strategies. So like maybe the tip skills, maybe above the accept skills, or trying to find a kind of more behavioral way to go about accept skills. So more of the kind of doing and less of the thinking, just because it can kind of be difficult to communicate that. In terms of risk assessment, that can be really difficult. So if somebody is just like not able to communicate what they're thinking or they're feeling, or they just, can't think about some of the things in a similar way. And so I would recommend maybe trying to think outside the box. And I have seen people who have come up with more graphic, like risk assessment things. So we could look into that. But yeah, and also if working with a teen, sometimes it's just talking to somebody, a loved one, a parent, ideally, who really have a good sense about like this isn't going well, and using them as a resource. Um, Somebody asked about tips for if somebody is addicted to um, non-suicidal self-injury or self-harm. Yes. So usually somebody is doing this because it is a very effective way for them to regulate their emotions. And so we want to validate that you have found something that works. Unfortunately, it has all of these cons, right? You're hurting yourself, you're concerning other people, it's putting you at risk for suicide. And so we want to see like what is working, like why are they doing this and what is working for them? And then what we would actually do in DBT is what's called like a pros and cons, and say like what's pro for engaging in self-harm, what's con for engaging in self-harm, what's pro for not engaging in self-harm, and what's con for not engaging in self-harm or finding some other strategies. And then we just want to give them some alternatives and have them practice it. Um, and just kind of highlight that like it might not feel as satisfying in the moment. And it's really helpful to have, those pros and cons so they can remember why they're trying something new, rather than engaging in these kind of old patterns. Somebody said they wanted those DBTRU videos. So I will put that in there at DBTRU on YouTube.
I
Uh,
received a question.
yeah.
Any best practices for safety planning when doing telehealth or out of state?
Yes, great question. So first of all, you want to know where they are. Before you even start safety planning, you want to know where are they located. And if they're in a different, state than you're not aware of the services, then you want to probably with them come up with like, where's their closest emergency room? Do they have a mobile crisis unit? These kinds of things as well. Previously, like before COVID, we would have said like, absolutely not, you shouldn't do it on telehealth. Of course, things have changed now. So you can do it on telehealth, but you want to kind of walk through with them and make sure they have access to some services before you start to assess. That's the key thing is know where they are. Of course, they could always lie. There's all kinds of things, they could always turn off the feed, and now you don't know what's going on. But I think that's kind of the key is to know where they are ahead of time. And I really like to use the share screen function, especially if we're doing a safety plan, because it kind of simulates that collaborative nature that you might have. So it's like we're filling this out together. Maybe I will even send it to them and have them type stuff rather than me typing stuff so that they're more engaged. So those are some tips I have for doing telehealth risk assessment and safety planning. Um, Here's a really good one. How do you support someone who is suicidal and does not have any social or familial support? So I think my first point is, what level of risk are we talking about? So if they're at a really high risk, then, we do what we have to do. Even if somebody did have all social support, we have to get them to the emergency room. And, if they're at a lower level of support, then we want to think about how can we get them into some kind of supportive relationships. I like to think about this as trying to help them build a life worth living. So maybe their family isn't supportive for some reason, and we can, mourn that and accept that and think about how can I go about building a support network? How can I build a chosen family? And are some things I need to maybe work on so that that's a little bit easier. I mean, do I need to work on my social skills? Do I need to get out there? Do I need to maybe do some what we call behavioral activation so that I feel more comfortable, not being so depressed and, rotting in bed and getting out and getting some social support because we know that's really, really protective for people who are at risk for suicide is having some type of social support. And one thing I'll say about that is they may not have a supportive family. And when suicide enters the mix, the family might change their tune, right? So it might not, they might not be supportive of their identity, or the way that they're living. And, they love that person and they want them to live. So sometimes it's like, would you feel comfortable reaching out to them now? Maybe we're not having a conversation, but, can you help me? Yeah, one person asked for tips for talking to parents once a child shares about thoughts of suicide. Um, First, I'll say before we talk to a child about suicide, if you're a clinician, you do want to highlight like what your obligations are about sharing with the family. I've been in that situation a lot where the child tells me something and they say, please don't tell my parents. Like, I promise I won't do anything. Please don't tell my parents. And you want to be aware of, whether you do or you shouldn't do it. I tend to err on the side of sharing with them, and I like to have the kid do it if possible. And so I will talk with the kid and say, we got to tell your parents. Um, we just need to tell them so that you're safe, that they can keep you safe. I will be there with you, but let's talk together about how we can tell them. What are you concerned about? How can you say it? How can we follow up with them if they get mad? How can we follow up with it to make you safe afterwards? And so sometimes they're mad at me, and I would say, you can be mad at me. I totally understand it. I would rather that you be safe. And so I'm doing this for your safety. I hope that you understand, and kind of pull them into the conversation as much as possible. Any other questions?
Thank you so much. We are at time, and thank you for all the resources you shared in the chats. It's just beautiful. That was our goal with this series, is to make it as practical and applied as possible. And I really appreciated how you have assessment tools and videos and the slides of other resources that people can actually take and use. So thanks for the time and thought you put into this. And thank everyone for being here today. And for supporting this series. We have 3 more next week. I put the flyer in the chat, and we hope to see you then.
Thank you, everybody. It was really fun. Bye.